Welcome everyone! Today we are breaking down the modern clinical architecture of pneumonia. For the USMLE, you must move beyond simply recognizing fever and cough. We will focus on the shifting taxonomic definitions, the cellular timeline of lung injury, and the strategic algorithms used to navigate community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-acquired pneumonia. First, let's define our battlefield. Community-acquired pneumonia is onset outside the hospital setting, whereas hospital-acquired pneumonia occurs greater than 48 hours after admission. Ventilator-acquired pneumonia is a subset of nosocomial cases, especially driven by endotracheal intubation. Note that the category of health-associated pneumonia is now deprecated. It failed to predict multidrug-resistant pathogens and led to the overutilization of broad-spectrum drugs. Instead, the modern standard is to assess individual multidrug-resistant risk factors such as prior MRSA, Pseudomonas and isolation, or IV antibiotic use, hospitalization within the last 90 days. Modern pathophysiology has moved past the sterile lung myth. Pneumonia is a dysbiosis where microbial entry, clearance, and regional conditions like pH and O2 tension are altered. Pneumonia is not just a localized lung event, it triggers a systemic inflammatory loop. This results in a significantly elevated risk of acute vascular events, including myocardial infarction and arrhythmias that can persist for up to a year post-infection due to plaque destabilization and direct myocardial invasion. So let's pay attention 1 year after the recovery. This is a classic pathology favorite for step 1. Stage 1, edema, early edema. Step 2, red hepatization. Step 3, gray hepatization. Step 4, resolution. In the edema phase, we have early proteinaceous exudate and proliferating bacteria, feudal valley. During red hepatization, massive influx of erythrocytes and neutrophils occurs. The lung tissue becomes firm and red, resembling the liver. After that, we have the gray hepatization, when erythrocytes disintegrate, leaving a fibronopurulent exudate. Gas exchange begins to improve as bacteria are cleared. The last stage, resolution, when the macrophages become the dominant cell type, clearing the debris so the inflammatory response can regress. You must differentiate typical from atypical pathogens. The typical pathogens, like streptopneumonia, is still the first one, and Haemophilus influenza are susceptible to standard beta-lactams. Atypical, like Mycoplasma, Chlamydia, and Legionella, lack a cell wall, making them intrinsically resistant to all beta-lactams. They require macrolides, fluoroquinolones, or tetracyclines. Their incidence appears to be increasing, particularly among young adults. They are referred to as atypical because they cannot be cultured in standard media and they're not visible on a gram stain. Intrinsic antibiotic resistance. A critical clinical feature of these pathogens is that they lack a cell wall, making them intrinsically resistant to all beta-lactams. Like I have a red speak. Because resistance to macrolides is a growing concern for mycoplasma pneumonia, with rates as high as 95% in China and between 15 to and 13% in the United States. We have to watch for MRSA-CA. It carries the penton-valentine leukocidine toxin, which causes severe necrotizing pneumonia and gross hemoptysis, often following a viral flu infection. Triage is about objective risk assessment. We have the CURB 65 with severity focus and PSI, Pneumonia Severity Index with the mortality focus. The CURB 65 score is your rapid severity focus. The variables are C, confusion, U for uremia, R, respiratory rate, B, blood pressure with systolic less than 90% or diastolic less than 60%. And 65, age greater than 65. I score equal 3 or greater than 3 mandate severe ICU evaluation. The Pneumonia Severity Index is more accurate for mortality, but harder to calculate at the bedside. Remember, definitive ICU admission requires one major criterion, like mechanical ventilation or septic shock, or three minor criteria, like respiratory rate greater than 30, uremia, or multilobar infiltrates. In the outpatient node, diagnosis is strictly clinical and radiographic. Sputum or blood cultures are not indicated. For inpatients, deployment becomes strategic. High-yield urinary antigens for streptopneumonia, pneumonia, and Legionella are fast and unaffected by prior antibiotics. Biomarkers like procalcitonin can help, but they are insufficiently accurate to withhold initial empiric antibiotics if you clinically suspect a bacterial infection. Treatment depends on comorbidities. Let's see the treatment algorithm. So the outpatient community-acquired pneumonia with no comorbidities and no multidrug-resistant risk factors, we have two options. Option 1, high-dose amoxicillin. Option 2, doxycycline. Option 3, macrolide. Only if for local pneumococcal resistance to macrolides is less than 25%. When there are comorbidities, you have to use a combination therapy. Option 1, amoxicillin clavulanate or cephalosporin plus macrolide or doxycycline. Option 2, with monotherapy, respiratory fluoroquinolone. like levofloxacin, moxifloxacin, and gemifloxacin. If they had we have to remember that if they had an antibiotic in the last 3 months, select an agent from a different class. Inpatient community-acquired pneumonia patients empiric treatment metrics. So, uh, for non-severe inpatients, a beta-lactam plus a macrolide is the gold standard. If a multidrug-resistant risk is present, prior MRSA or Pseudomonas, you must add coverage immediately. Linezolid is preferred over vancomycin for MRSA in the lung due to better tissue penetration and its ability to inhibit bacterial exotoxins. Just to remind us, today we don't use healthcare-associated pneumonia anymore to identify patients at risk for resistant infections, because it was found that this classification is an unreliable predictor of resistant pathogens and led to the dangerous overutilization of broad-spectrum antibiotics, such as those targeting MRSA and Pseudomonas. So the current clinical paradigm mandates assessing individualized MDR risk factors for every patient. Now we're going to talk about hospital-acquired pneumonia and ventilator-associated pneumonia. So the nosocomial infections are a different breed. Early onset, less than 5 days, pathogens often mirror severe CAP, the community-acquired pneumonia. When there is a late onset, greater than 5 days, or prior antibiotic exposure, it marks a radical shift toward multidrug-resistant organisms like Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus, and extended-spectrum beta-lactamase ESBL producing enterobacteriaceae. Pseudomonas is particularly dangerous because it can develop resistance during treatment. When an infection caused by extended spectrum beta-lactamase producing bacteria is suspected or proven, carbapenems are generally the preferred treatment choice. For highly resistant strains, newer combination therapies may be utilized. Why does ventilator-associated pneumonia happen? The endotracheal tube creates a biofilm reservoir that shields bacteria from immune defenses. It also neutralizes the gag reflex, allowing secretions to microaspirate past the inflated cuff. Critically ill patients often enter a state of host immunoparalysis, leaving their alveolar defenses overwhelmed. VAP diagnosis is difficult because tracheal colonization is nearly universal in the ICU. You can use quantitative cultures with a threshold 10 to 16 for ETA to differentiate colonization from infection. However, the clinical approach prioritizes high sensitivity if cultures return negative for MDR pathogens. The key principle is to immediately de-escalate to save the patient's microbiome. If there are no MDR risk factors and low mortality risk, Monotherapy with pipitazole or cefepime is appropriate. If MDR gram-negative risk is high, you must use dual antipseudomonal therapy from two different classes. For ventilator-acquired pneumonia, a 7 to 80 day duration is as effective as longer courses and helps prevent future resistance. Hospital-acquired pneumonia is defined as pneumonia with an onset greater than 48 hours after hospital admission. It accounts for approximately 70% of all nosocomial cases, while 70% of all hospital-acquired pneumonia cases are acquired outside the ICU. They are ward-based. About 30% of all patients eventually require mechanical ventilation. Patients with hospital-acquired pneumonia who are not intubated generally have better host defenses and a higher frequency of non-multidrug-resistant pathogens compared to those with ventilator-acquired pneumonia. Ventilator-acquired pneumonia. So ventilator-associated pneumonia is a subset of nosocomial pneumonia specifically associated with mechanical ventilation via endotracheal intubation. It counts for hopefully 30% of nosocomial cases and develops in about 10% of ventilated ICU patients. VAP risk is categorized by time: early onset, less than 5 days, pathogens mirror severe community acquired pneumonia, like streptopneumonia and Haemophilus influenza. Late onset, greater than 5 days, there is a radical shift to MDR organisms. Prevention is the best treatment. So for community-acquired pneumonia, we use the pneumococcal PCV13 conjugate to generate long-lasting T-cell dependent memory and PPSV23 polysaccharide for broader coverage. We have the influenza vaccine and antivirals. Oseltamivir prophylaxis is recommended during outbreaks until vaccine antibiotics peak. Another important factor is smoking cessation because it's critical to restore mucociliary function. We have some strategies in the ICU to prevent like a prophylaxis from to ventilator associated pneumonia, like elevate the head of the bed to 30 to 45 to reduce respiration degrees. Use daily sedation vacations to facilitate weaning and prioritize non-invasive ventilation, whenever possible, to avoid the ATT altogether. To summarize, individualized risk assessment has replaced broad HCAP defaults. Aggressive de-escalation based on real-time culture and PCR data is an absolute imperative for STEP wordship. Pneumonia has a long tail of systemic risk. Monitor your patients for cardiovascular events long after their lungs appear clear. Thank you all for your attention. Good luck with your prep.